Welcome everyone to today's ED Stop Suicide QI Collaborative Fireside Chat. My name is Laura Aird and I work for the EMSC Innovation and Improvement Center. Today's topic is mental health assessment and community resources. We are so grateful to our colleagues at HRSA who support the EIIC, this collaborative, and this event. The contents of this presentation are those of the authors and do not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. Thank you so much for being here today. We know you are busy. We're very excited about today's presentation. There are slides at the end that talk about contact hours or continuing education credits for physicians, nursing professionals, social work professionals, and others. If you'd like to put your first and your last name in the chat so we can verify your attendance, that would be helpful. It is required for nursing professionals. Please remain on mute for the entire presentation. This fireside chat is being recorded and we will post the recording online along with the slides. You'll notice that you have both a Q&A and a chat feature at the bottom of your screen. So you're welcome to use both. We hope that you will put the questions in the Q&A feature and then your names and any other communications in the chat. If there's time, we'll have discussion following presentation. And there is an evaluation at the end, and we hope that you will stay to complete the session evaluation because your feedback is very important to us. You can see the objectives on the screen for today's talk. I'd like to turn this over to my colleague, Mo Saidinejad, to introduce our distinguished speaker.
Thank you very much, Laura. Really appreciate that. It is a great honor and great pleasure to introduce our speaker today, Dr. Vera Feuer, a great friend and a colleague. I've worked with her for several years, and she is indeed has had a distinguished career. She's currently the Director of Pediatric Emergency Psychiatry at Cohen Children's Medical Center. She's the Associate Vice President for the School Mental Health Program. She is Associate Professor of Psychiatry, Pediatrics, and Emergency Medicine. And as well as that, nationally, she serves as the co-chair of the Emergency Child Psychiatry Committee of the American Academy of Child and Adolescent Psychiatry. And she has been the immediate past president of the New York Council on Child and Adolescent Psychiatry. She completed her residency training program at Drexel University, as well as a fellowship in child and adolescent psychiatry at Hofstra Northwell Health System. Her expertise specifically is emergency psychiatry. She has been instrumental in developing the Northwell Health Emergency Telepsychiatry Network. She has led the opening of the Behavioral Health Urgent Care Center at Cohen Children's. Most importantly, she is extremely involved with the school-based programs, and she has led the community-embedded schools serving urgent care centers, as well as collaborating with the school districts to expand the access to mental health for students, as well as to provide community education and professional development to school communities. She will be our fireside speaker this afternoon talking on our bundle 2, which is assessment of a patient who has screened high for suicide risk. Again, great honor and pleasure to welcome Dr. Vera Feuer. I'll pass it over to you, Vera.
Thank you so much, Mo, and thank you for including me in this amazing effort with this collaborative. I'm really excited to come and talk to you guys about some of the models that are out there for emergency assessment, care models of various resourced and various needs areas. Also, we'll talk a little bit about community care models and kind of the upstream work that I have been doing and others have been doing in this country country about being able to provide community connections, community crisis services, and what are those models out there. And then we'll talk a little bit about what is a mental health provider, a psychiatrist that provides an evaluation in an ER. What does that look like? What does that include? And why is that helpful? And then we'll talk on telepsychiatry a little bit about how that might be of resource and help for all of you. So next slide. This is a slide that I often use, and it really looks familiar if you work in an emergency department. We know that the rising rates of mental health referrals to emergency departments in pediatrics has been a trend in this country well before the pandemic and further exacerbated by it. Regardless of what kind of insurance people have, regardless of where you live in the country, that rise is evident everywhere. And it's a multifactorial issue where we have a lack of community-based services, less beds than ever before, many states losing a lot of inpatient beds, a lot of residential beds, limited access in the community to behavioral health care. There's a lack of early intervention. Historically, EDs are not necessarily equipped to handle these kinds of problems. So systematic ability to screen, treat, and refer is something that has been thought to be the cause. And then lack of parent-child engagement. All of these issues leading to this circumstance where families really have nowhere else to go but the emergency room if they are trying to get some sort of urgent assessment for their child. And so everybody refers kids to the emergency room, schools, community-based organizations, pediatric providers, families, child protective services, many other agencies that are probably not listed here, but this results in many, many concerns. And the next slide will tell us there's many concerns about providing mental health care in emergency settings. Using the emergency department for routine mental health care, the same as for primary care, leads to inefficient use of resources, cost shifting. As we know, we have already strained and overburdened emergency systems. As it is, it not only often provides inefficient care for the patients coming with the mental health complaint, but also obviously impacts on everybody else in the emergency department. Also, often these patients and the complaints that they're coming with, or how ready an ER is to manage them, can yield many safety concerns for the patients themselves, safety concerns for the staff, and oftentimes the emergency room is suboptimal environment for mental health engagement and de-escalation, right? It's not really the best environment to be doing emergency assessments for mental health in. There's also no clear care standards. If you do a literature search about what really is the care standard that is needed, what are clear guidelines that are needed to manage these patients in the ER setting, we're still really lacking in literature, although in the last several years, and partially our mission as an emergency child psychiatry committee for the Academy of Child Psychiatry has been to try to develop care standards, but it's difficult. Research in this area, as you can imagine, or as you know, is very complicated. So consensus guidelines, some soul studies, those are the things that can guide care standard development. And I believe the last Fireside chat, my colleague, Dr. Hoffman, did talk about the agitation guidelines that were developed, for example, that has been a result of our committee's work. But really developing and continuing to develop care standards of how these patients need to be managed and how these families need to be managed, what kind of care they need, what guides their assessment, their screening, still remains an area for further research. Next slide. So really, what are the different models from a systems of care perspective of caring for mental health patients and youth with acute mental health issues? We will talk about this later, but there are definitely, and the largest need for them, and we need more of them, is community-based programs. Of course, if kids can be managed in their community, in their usual environment, in the least restrictive setting, with intensive in-home supports, family guidance, individual treatment, school connections maintained. That is really the best for them. So really, those programs have a really, really important role, and often, unfortunately, are under-resourced and underfunded, but there's many great programs around the country and many great models, and I'm going to talk about them. And oftentimes they are state-funded or grant-funded programs. Then we have hospital-based clinic models where certain hospitals are able to expedite kids into their outpatient clinics, or urgent care models, which I'm also going to talk about as part of the community crisis care continuum. And then we have developed in the recent decade, especially, the models have grown, and research around them has grown to support that having programs in the emergency department, having expertise in emergency departments, having teams in emergency departments does have benefit, even in places where maybe the volume of behavioral health patients is not high enough to have a large program or a multidisciplinary large team, which is that last most inner circle, the dedicated child and adolescent psychiatry emergency programs. But even in places where there's any children, having some sort of program, some sort of solution, definitely tremendous amount of research around the benefits of that. So to expand on the ED-based programs specifically, next slide, yeah, next slide. In the intervention bundle number 2 that we'll talk more about later, and that will be available to your consortium, there is evidence that's cited about the value of mental health assessments and the knowledge that mental health care provided by primary care emergency doctors often not sufficient to meet the needs of children in a mental health crisis or after a crisis, and that various surveys and different studies that were done really find that both qualitative feedback from clinicians on how important this is to have specialist staffing and mental health personnel, and then also evidence that a designated team improves organization flow, leads to significant length of stay reduction, safety event reduction, return ED visit reduction. And so all of those quality metrics happen when you have a team-based approach. And it always works best when it's embedded in your system of care and framework locally, and connects to other services in the community and really engages other entities, because the ER is never the end of the journey for these patients. They need connections. Next slide. So if we drill down on what are the different programs on an ER level that exist, there's various different components, and really ER programs typically tend to focus and need to focus on providing evaluation, risk assessment, expert guidance, and then connections to care. And there's different ways that, that people do that. The enhanced evaluation and referral model maybe is the least resource intense model, and some ERs have either a master's level clinician or a social worker who is able to identify patients, help facilitate rapid referral to various outpatient services, and then work with the families on things like safety planning and education around restricting lethal means, having support for them when necessary, reminding them of their appointment coming up. So providing that level of support, many places utilize that model, and it definitely has evidence around it being helpful and beneficial to those families. Other models really focus more on the intervention as well. So not just referring and connecting families and attending to their highest risk needs, but also really employ therapeutic approaches where you have clinicians or again, mental health providers that are able to work with the families, work with the kids themselves on providing crisis and family-based interventions more robustly, and able to have that intervention and have that process of therapeutic engagement and skill building start in the emergency department and then connect to outpatient resources. The child guidance model has also been utilized by many places. It's also included in the Critical Crossroads Toolkit that is a resource for you all that I think has been mentioned in the other Fireside chats as well. And that model really combines typically psychiatric social workers, or in some places other master's level psychiatric clinicians, could be psychology, could be mental health counselor, that do the clinical work with the families, work with the kids, work on the assessments, but that are supported by a child psychiatrist, either in person or telephonically, or a combination. Many places have a combination where during the day it's in-person supervision, at nighttime it's telephonic supervision, or it's only in person for high-risk cases and, you know, telephonic for the lower risk cases. But really the idea here is that the master's level clinician social worker is the frontline evaluator and worker with families, and the child psychiatrist helps support that. And we're going higher in the intensity of resources and services here. The next one is having a psychiatric consultant to the emergency department. I think this is a very common model in a lot of ERs, where you have not somebody embedded necessarily in your ER, but you have access to a consultant that you can call, similarly to other subspecialties, to provide a psychiatric consultation and you know, I guess answer specific consultative questions, whether they're around a medical differential or managing delirium, or whether they're around you know, the need for hospitalization or assessing risk, whatever it is. Those programs, those psychiatric consultant programs address that. And we'll talk about telepsychiatry later in more detail. But of course, telepsychiatry in many areas is the psychiatric consultant to the emergency department, but again, particularly in areas where there's limited local resources, or where the number of patients presenting is low. Again, it might make more sense to have a consultant that comes as needed or beams in virtually as needed versus having a full team on site. And then the last one is the psychiatric emergency service models that are the most comprehensive, typically multidisciplinary teams, mostly make sense in areas where there's really high number founded on that psychiatric emergency, comprehensive psychiatric emergency model. And it usually includes big teams that provide psychiatric assessment, therapeutic environment, where social support, the medical assessment, the psychiatric assessment, therapeutic interventions, connection to community care, all bundled into one place, and typically fairly resource intensive, and really can have great results, especially again in places where there's a high volume of patients that need to be managed. On the next slide, I'll just briefly want to refer to my own institution went through a change, and we have a sort of hybrid model between these last two things, between a consultant to the ER versus a big dedicated psychiatric emergency program, because we have a model where we are still embedded in the emergency room, but we went from what was the black on this figure, a regular nursing triage, go to the room, see seen by the nurse, seen by the ER provider, call the psychiatrist for a consult, which is your regular consultative workflow. We went to a workflow where we said it makes no sense for the psychiatrist to wait when we know that these kids are coming here for behavioral health. We have a lot of them. We have some area in our ER. Although it's small, but it's secure, it's safe, it's equipped for specifically for behavioral health patients, to bring them in there and then separate out high acuity, low acuity patients, and who can be sent to our urgent care, which is our ambulatory service in the building, who can be triaged out of the ER, and to do all of that prior to the emergency medicine provider necessarily getting involved, because our team is large and there and present to manage the many patients that we have. So we're still technically consultants. The ER attendings are the primary attendings of the patients, but the assessment happens parallel to one another and begins with a behavioral health triage, which I believe was also in detail reviewed in the last Fireside chat by Dr. Hoffman. So next slide. So target areas for these ER models are really about screening patients and evaluating them for their psychiatric complaints. It is also important for these programs to help with how these patients are managed within the department. So removing them potentially from the main ER to a more secure or more therapeutic space, stabilizing and releasing patients that really don't need to be kept in the hospital but might need some intervention. Really important outcome of these programs is preventing unnecessary admissions, because the higher you go in expertise of who assesses the patients, the more nuanced the assessments become and the more robust the interventions become, which can oftentimes make the difference between needing to admit a child or discharge a child, which becomes so important in this day and age when we have really limited number of beds and we really need to prioritize our sickest patients and really use any other resources that we can to support patients that might need immediate treatment, but maybe not inpatient treatment. And there is a big difference between the two. And I think oftentimes, even if it's, adult psychiatrists or residents or social workers or other providers that don't have as much comfort with the assessment or the interventions, it makes sense that they're erring on the side of caution, and maybe having the experts helps prevent unnecessary admissions, and then also helps with appropriate follow-up outpatient services, because those two things go hand in hand. Again, a lot of these kids do need immediate help. A lot of these families need immediate support and immediate or as soon as possible help. And that's only possible if we have the resources to be able to provide that for them. Next slide. Of course, the care that we provide and the intervention and the assessment has to be patient-centered, or, pediatrics family-centered and equitable, has to make sense for all. And next slide, in pediatric psychiatry and emergency psychiatry, what that means is really family-centered perspective around what these patients are coming with. So the patient enters the emergency department because they need our help. They identify that they're in such a crisis that they can no longer wait and they're going to seek our help. So I think the first and foremost, we have to appreciate that for what it is. And really the immediate thing to do is helping them find comfort and safety, because that is what they're looking for. And that is what triaging and assessing their complaints is all about, is figuring out how to provide them comfort and safety. Then next, we really need to think about how can we relieve their immediate distress? Are there things that we can begin in the emergency department? Are there interventions? Are there medications, therapeutic interventions, family interventions, safety planning, all these things that we're going to continue to be talking about in this learning collaborative? Those are the things that we can help families relieve their immediate distress. And in pediatrics, the distress is not always the child's or not always just the child's. The distress is often with the family and with the parents or with somebody else that identified that there is a problem. So really being mindful of whose distress do we need to relieve and who's seeking the care and how do we need to address that is part of the assessment that we do, and really important from a family-centered perspective. And then last but certainly not least, these complex programs will only achieve their goals and will only keep patients out of the emergency department and connected to care if we're able to have them leave this circle in a way that we're supporting them coping with distress long term. So what are the tools? What are the resources that we can give them, we can provide them, or we can navigate them to that will help them cope with this distress long term so that they do not need to utilize the emergency department and that they get the kind of help that they need in the right place, right time, and the right kind of care. Next slide. So again, many benefits to having a multidisciplinary team, having family-centered practices, having a child and adolescent psychiatry-led or overseen multidisciplinary team. If the resources allow, is always best. And then having staff training is a really, really important component, and building out your own resources and looking for who on your teams can be part of this care network. So if you have patient engagement specialists, child life specialists, occupational therapy, security, what are the ways that we can help teach them so that they can help provide us that family-centered care where we're relieving the stress of our patients as we're communicating them, as we're providing them with tools, as we're guiding them. We at our institution, for example, use agitation simulations as a learning tool because it's a multidisciplinary tool for everybody to practice together. It's easier to build into busy schedules because there's a, usual, the ER staff is used to practicing in simulations, right? So we run behavioral health ones where we're practicing some of the verbal de-escalation skills and other skills that are necessary to keep families and kids comfortable. Developing youth and family education, getting resources in your ER that your staff can provide or the teams can provide, or developing your own about what families can expect while they're in the department, while they're outside of the department, if they're boarding, waiting for admission, what they can expect, what can they expect from an inpatient unit. We have developed, and I have some examples on the next slide, but we have developed a series of education in various topics for families to take home. So considering that, how again, those kinds of tools can help support ongoing coping and ongoing support outside of the ER, and how can we continue the interventions we begin ongoingly, that's one thing to consider. Creating standards for boarding patients is extremely important. We have our emergency departments these days filled with patients awaiting psychiatric beds, and really how we manage them is so important. I'm going to talk about it a little bit more in a second, but creating your standards, your pathways, what are your policies, really, really important for each of your institutions. And then we have some picture examples of some of our spaces and our tools. We have a de-escalation room. We have this cart that's called the Be Mindful cart with the cute little bee that has all kinds of coping tools in it, box with things that kids can use. And then on the wall in that room, you can see all the education that the families can take as they're waiting. Next slide, just an example of the family education here. This one's for major depressive disorder, but we have them for about 30 different topics, diagnosis we're giving, therapeutic modalities we're educating families on, safety planning, safety in the home, how to de-escalate at home, special topics, really any mental health, the most common things we manage, school avoidance, adjustment issues, all kinds of things. And what's nice about these these materials is that they include a brief description, but they also have book recommendations, websites, apps. It's things that we hope families use well after the visit. Next slide. Just a few words about managing patients who board in your emergency department waiting for psychiatric bed. Again, really important to attend to this group's needs because inactivity and that waiting that they have, that uncertainty, really leads to just more depression, agitation, anxiety, unless you're able to engage the patients and communicate appropriately with them. There is this resource here from the Emergency Nurses Association called Tips for Providing Safe and Structured Environment for Pediatric Behavioral Health Patients. And it is really helpful because it provides this guidance on how you can create something called block schedule for the patients, where you have some sort of structure for their day, where you make sure that your teams remember to feed them, to bathe them, to have them call their families, to engage in some kind of activity, to communicate with the providers, to have options for therapeutic activities that they can do. And you don't have to think big. Therapeutic activity is playing Uno or doing anything really. What are your local resources that you can give them? And I have another picture here that shows our pilot when doing this in our emergency department with little paper magnets, because they're safe for the patients. They're magnet paper where they get to choose from different things of how they want to structure their day. If they're spending the full day with us, we know because there's no beds for them, really helps them take control, feel better, know what to expect, and helps our staff make sure that proper handoffs and all the needs are met. Next slide. So what the assessment itself, the psychiatric assessment itself focuses on safety. We do use various screening tools at the nursing level, and we've talked a lot in other sessions, and there'll be more focus on the suicide screening tools. That is the most commonly used tool, but there's other substance use screening that many emergency departments use, abuse, human trafficking, some of the other things that we screen for, and those are very helpful and informative. There are a few emergency departments, but very little evidence for the value of doing clinical rating scales in the emergency department, because the focus in the ER is really not very refined differential diagnosis that we're trying to make, or a severity. What we're trying to decide is a disposition, safety, what are the needs of the family, and what do we need to do immediately for them. For that reason, for kids, the assessment of any child really has two major components: review of the psychiatric symptoms, risk factors, and then assessment of social factors and the context that they are living in, and what are the things that are influencing the patient's functioning, the patient's future care plan and follow-up. What are the family's barriers potentially to following up, because those things will influence decision-making. And the length of child consultations will always be longer than those of adults, because we both need to work with the kids to establish rapport, and that takes time. And then also to evaluate any child, you really need collateral information, because kids, especially in the emergency context, are often not the ones that ask to come to the emergency room. Sometimes they are, and sometimes they're reporting distress to their families, but a lot of the times somebody else was concerned about them. And that somebody else is often not even the parent. So how many times have you seen kids sent by school where the parent comes and says, oh no, everything's okay, I'm not sure why they sent them. And then if you do end up talking to the school, you find out a whole slew of things that have happened that concern them and rang the alarms. So really important to consider what are the collateral sources that you can get: parents, caregivers, whoever referred the child, whoever identified the crisis, identified the problem. But they might be in the know about things that other people might not be, because they're the ones that thought that this visit was necessary. And then, existing providers that know the patient, pediatrician, therapist, school, all of those people, if at all possible, are very helpful to involve. Now, understanding that in the emergency room, there's definitely limitations to being able to speak to this many people, but we do try best practice to at least speak to the people who had referred them. And then if they have existing providers and you're sending them back to their care, you should speak to the people that you're sending them back to. The child evaluation itself, it's a clinical interview, really have lots of considerations here, and many of them have to do with the developmental considerations, language considerations, of course, cultural considerations. Also, developing the rapport with the child, really important to understand about the circumstances of the visit. Really important question that the kids have oftentimes, or something that we have to discuss with them, is privacy and confidentiality, which they have the right to. However, often in the emergency department, we do have to inform them and talk to them about the limitations of that, because for safety purposes and risk purposes, of course, oftentimes we do have to share things with their parents that they have to know in order to keep them safe, or to understand the need for an admission, for example, and we have to talk to the kids about that. So those all weigh into how the assessment is done. And a lot of these issues with regards to privacy and confidentiality also vary state to state in terms of age that and the type of information that gets released, even outside of a safety context to a parent from a child. So there's multiple consent levels, all these things that need to be considered. And then when considering disposition options for kids and adolescents, really important to consider, again, the family's capacity, limitation, insight, supervising, or the capacity to supervise, the capacity to engage with, understand, and enact safety planning, lethal means restriction considerations. So all of those things will weigh into the assessment and will help make our plan. Next slide. Other than the assessment, like mentioned earlier, really many other reasons why mental health teams are helpful, and the services that they provide are important for all patients that are in the emergency department, helping support safety planning, psychoeducation, providing continued reassessment, especially to patients that are boarding, especially if we are able to initiate treatment in the emergency department in a day or 2 days. If there is an opportunity to reassess and make an alternate plan, that is a really important way that these mental health teams can be helpful. Initiating medication, managing medication, changing medication, adjusting things, managing side effects, those are things that they can weigh in about. Brief family and individual interventions, which I mentioned earlier, skills training, helping families improve communication, the crisis itself, and what the ER, even though I earlier said is not the best environment, sometimes it yields a circumstance in families that sort of makes things bubble over and will allow kids to share things with their parents, or allow parents to gain insight or have understanding of things that they didn't before. And that can be very powerful and can really be an intervention in itself. So I will often say that the ER visit itself can be an intervention if we use it to our advantage and turn it and reframe it for everybody involved as something good that happened that is going to lead to help in the future. And then disposition planning and collaboration with community providers. Next slide. Community crisis model, I'm going to switch to a little bit of what's available out there in the community, and I'm going to just briefly touch so we have time for questions at the end. You guys are familiar with hotlines, and triage hotline exists. For example, in Rhode Island, they have a program called Kids Link where community and schools can call a central hotline to get connected to services or to be referred to the emergency department. New York has similar, in New York City, many other places have, where it's providers answering and help do some interventions or guide treatment. There is evidence for hotlines in engaging patients, girls more than boys. And also teens prefer crisis text lines often to actual phone lines, which now also exist. It can be effective, especially in immediate proximal intervention. There's not much evidence that they help in the long run, but they can be really helpful in diffusing an immediate crisis and allow that temporary stabilization and connection to other services. Community models that exist also vary, and just to mention some best practices. So mobile crisis exists in many states. Connecticut has a system that's worth checking out, that we have a citation here for some of their published work on their program. They have within the entire state of Connecticut, which is a small state, a 45-minute response time where a clinician can respond. It's not 24/7, but pretty close, where the hours and families, schools, primary care, anybody can call. They'll go out to ERs to establish connection for a family. They serve as a discharge plan for ERs to continue treatment in the community. And then they often also are the referents to ERs because they'll go to a call and they'll decide that bringing into the emergency department is best. So oftentimes they are working hand in hand with their local emergency departments. We have them in New York City as well. Many times they are grant-funded or state-funded programs. Home-based crisis programs are similar, but a little bit more robust. They typically establish connection with families for about 45 days or longer, about 6 weeks or sometimes longer, and really help support families extensively with family education, peer support for the parents, care management, connection to care, engagement with the kids themselves. Many examples of this also around the country. The citation and the graphic example I have here is from Oregon, from a program called Crisis and Transition Services, but these programs exist elsewhere also. Community paramedicine in some states have become a crisis model that instead of the traditional mobile crisis model where it's a clinician, a mental health clinician driving to the crisis, it's a paramedic team that responds, that has some embedded mental health expert on the team and maybe virtual support from psychiatry, and they can, similarly to any other paramedics, go evaluate, stabilize, treat, and either connect or bring in. They're very novel programs that I think have a lot of promise in the future. And then I'll speak briefly on the next 2 slides about our programs in New York with behavioral health urgent care and our school partnerships. So on our next slide, behavioral health urgent care is an ambulatory crisis model that we have embedded in our hospital, where we have a child psychiatrist on a hospital-based service that's not a 24/7 service. It's limited hours, but that provides access to the community so that they don't have to come to the ER. They can come directly same day, next day to another place where their child can be assessed by the child psychiatrist, where they can get connected to care. They can get started on medicine if necessary. We provide temporary bridging care if necessary. And our results show that this really has helped us manage our ER volume, our borders, our inpatient admissions, and improve our connections to care in general. That program, on the next slide, we had enhanced with working with schools and developed a comprehensive school partnership program here in Long Island, where we now have partnerships with 40 school districts in Nassau and Suffolk County, where they participate and financially support behavioral health centers in the community that provide that sort of urgent access to families, to school professionals, professionals so that they don't have to send to the emergency department. They have another place to send. And we really enhanced the model and merged it with school-based mental health models that focus on more preventive services as well. So in addition to the work we're doing with them in the crisis programs and the clinical programs and access we give to the families, we do community education, professional development, consult to the school district, really providing a wide variety of services. And our work together has led to a 60% decrease in these schools referring students to the emergency department within a year of partnering. So I wanted to highlight those as some examples. And then last but not least, to mention telepsychiatry for a moment. Telepsychiatry, especially, next slide, in the pandemic has emerged even more so as a potential solution for the access issues that we're having. And even before the pandemic, we already had tremendous evidence that this is effective. It's acceptable by patients and families as well as providers. It shortens length of stay in emergency departments. It's cost effective and it reduces barriers. And there's tons of literature even before the pandemic that this is true. And there were many regulatory barriers in the way of the virtual explosion that the COVID pandemic sort of removed from one moment to the next. And as we say, the genie is out of the bottle, and virtual care in mental health and telepsychiatry really has provided a whole new slew of services and access to places that could not have access to mental health supports before. Next slide. So in your bundle, you will have some guidance on how to start a telepsychiatry program, if that is the resource that you're choosing, and how to get engaged. And if you have limited resources, considering this is an option might be really helpful. Telehealth programs can also be supported by statewide mental health care access programs. And you see a map here, and on the next slide, there's a resource to identify what are some of these programs by your state. But there's many programs that provide child psychiatry, telephonic support, or other support to places that might be of help and of consideration for your region if you fall in that resource scarce category. And I think that concludes my portion. Hopefully we have some time for questions, and I have some resources to share. The little puzzle slides here are the integratedcareforkids.org websites developed by the Academy of Child Psychiatry, and it includes all these programs that have child psychiatry access across the country. There's the Critical Crossroads Toolkit that has been mentioned before as a compendium of resources for all of you guys. I also included the practice parameters for psychiatric assessment of children and adolescents if you want to read in more detail as to what goes into a clinical interview of a child and what are some considerations for that. And there's a national consortium of telehealth resource centers that provides resources that I included as well. So back to Laura to close us up and to maybe answer some questions.
Thank you so much, Dr. Feuer. And thank you to everybody else behind the scenes who helped make this fireside chat happen. It was critically important and included a lot of resources and a lot of information, and we really appreciate your time here. Next slide, please. So in a moment, we will be launching a poll, very few questions, but it's very important for anyone who is seeking especially MOC Part 4 credit, so for physicians. It's also important for others as well. Next slide. For nursing hours, you can see the QR code that you will need to click on in order to go to your evaluation to complete it to get your credit. Next slide, please. There is a link here that you can go to. Lenny, when you get a chance, if you could copy that and put it into the chat, if that's possible, and it doesn't disrupt the slides, that would be great. Social workers and a few other groups of professionals can link there and go to get their credit hours as well. And then just to mention, you've heard a little bit about the bundles. There are 4 along with a welcome kit and a quality improvement implementation guide that will be posted online. We hope next week. We've been delayed and we apologize for that. And then people's spring breaks and vacations, which are very important things, sort of allowed those to be pushed back just a tad bit. But we hope to have those out to you by next week. And I will turn it back to my colleague, Mo Saidinejad, to talk about any questions that folks may have or issues that he wants to raise.
Thank you so much, Laura. Just before the questions, I just wanted to add again, we put in the chat a bunch of links of different resources. Many of you guys are already familiar that the EIIC also specifically have put together tremendous resources. There's actually a pediatric education and advocacy kit called PEAK that is specific to suicide. There's also one that we have for agitation. So I think, Vera, you don't know this yet, but I just emailed you about this. The interactive learning module for agitation is finally up on our website. So that is one of our resources where you can basically, it's self-paced, sort of a choose your adventure kind of a interaction, talks a lot about verbal de-escalation strategies for one thing. So those are in the chat. And the Critical Crossroads Toolkit, which is basically the basis of all of this, is a 104-page PDF that is put together by a large group of multidisciplinary subject matter experts that included Vera and other people as well. And that is also a very important tool. Again, you find all of these at the EIIC site. So I wanted to take a look and see what we have for questions. So what I see in the Q&A from our own Dr. Chip Schreiber here in Los Angeles, wondering what our presenter thinks of the federal court ruling for no ED boarding in New Hampshire.
Yes, so I mean, I can tell you what I think, and then I can also tell you what our yet unpublished, but hopefully soon published expert consensus panel thought about where patients should board. You know, so I wasn't actually familiar with the ruling, so you know, thanks for letting me know, but it's interesting. But you know, there's no clear evidence that boarding necessarily on medical floors is any better than boarding in the emergency department, because it really depends on local resources and local practice, and that is what our boarding consensus panel thought as well. As far as practice goes across the country, it's split 50-50. Some places always admit to their medical floors, and that's where they feel they're better resourced and better able to meet the patient's need. And some places keep patients in the emergency department because, let's say, like at Cohen's Children's, we have safe space, trained staff, a multidisciplinary team, and are sort of better equipped to manage and treat the patients than perhaps the medical floors are. We also move patients relatively quickly. They have access to showers, they have access to the things that they would need. So I would say that I don't know that a federal ruling should decide this statewide, because I think it really depends on local resources of what's best for the patient and the family. And I think institutions, when they make decisions about this, that is what they need to weigh in. What are their resources and where the patient's need might be best met.
Very excellent. Thank you so much. So
30 days.
Yes. So I have a question for you as well on this. So I'm assuming that majority of folks who will choose this bundle of assessment would already have in place a validated screening tool that allows them to come to a point, I have deemed this person to be high risk and I need to do focused assessment. Can you also talk about the importance of choosing the right screening tools so you can end up with the correct targeted population for assessment so that people know that they have correctly identified those at high risk, because that is always a challenge. How do we know which of these patients are at high risk? So how does the screening part play into assessment?
Yeah.
How does that set the foundation?
Yeah, so I mean, that is where it all begins, right? We have to identify the patients. So I think using either, I mean, there's various tools that you can use. Having something like the behavioral health triage scale, the mental health triage scale from Australia that I believe Dr. Hoffman also mentioned last time and is used in my institution as well, can be very helpful because it's able to help identify a wider variety of problems and determine how severe they are, because that severity and acuity guides what kind of resources the patient will need. There's also value in utilizing, specifically suicide screening tools for, are the most widely used and we have the most robust evidence behind, and universal screening tools that can help screen your entire population to identify things, even if they're not there for a behavioral health issue, is an added consideration that I think emergency departments need to employ. And the ASQ, the Ask Suicide Screening Questions, and the Columbia Brief Screening Tool is the ones that have the most robust evidence and most support in terms of how to utilize and roll out in emergency departments and how acceptable they are, and there's additional resources. So those are very helpful, and they have different, again, it's the purpose is a little bit different because one helps identify suicidal patients in the entire population, which is really important, and the other one helps better tune in on the behavioral health acuity of patients, which then really guides who are the highest risk, not just for suicide, but for other things, and how can we attend to them first.
Yeah, thank you so much. Can you also say, let me see, I have another question here from the audience. So thoughts on the USPSTF stance on suicide screening for children and youth, i.e. not for routine use in primary care?
Yeah, so I mean, there's been so much about this, right? Whether suicide screening should be adopted in primary care. I mean, we have the depression screening adopted in primary care in many places, and some places have adopted suicide screening. I think always the concern about screening for suicide in primary care is that there's no resource to provide when that screening happens. And as we know, the value of screening is only as good as the response to positive screens. So I think many places have the stance that, schools, by the way, are the same, right? Primary care and schools, that, until we really have robust enough systems to support positive screens, there's limited value to the screening. So again, I think it is one of those things that, there's not been a universal recommendation made because of that consideration. But I think is a worthy goal. I do think we need to work towards making resources available to either our local communities and pediatricians, or however we can move the needle nationally, advocacy and whatnot. But I do think that universal screening in pediatrics and schools is going to be important going forward in general in this mental health crisis.
Thank you so much. We only have a couple of minutes left and we wanted to be able to launch our poll. So I'm going to go ahead and ask us, whoever is doing the poll, can we launch the poll, please? And as you're responding, thank you so much for your excellent presentation, Vera. I had meant to ask you a little bit about the 988 National, because I think if people don't immediately have access to any of those five models that you mentioned, not even a psychiatric social worker, how appropriate is it to just call 988 regardless of where you are and what kind of environment you work in? So if you have maybe 10, 15 seconds, you can quickly comment on that.
Yeah, absolutely. I think it's a great resource. It connects folks to their local resources. So 988 has the capacity to be able to connect you to what's in your area, and maybe you're not aware of some community programs or other things that may be available, or how they can support the families. So I definitely think it's a great resource. It's a great resource also for families. And I would highlight that it's not a suicide hotline. It's a general crisis hotline to get connected to resources, to help with any kind of mental health need or crisis. So sometimes families are hesitant to utilize, or kids are hesitant to utilize, because they don't, they're saying, well, I'm not suicidal, I just need a therapist. Well, if you need a therapist and you call and you're not finding one, and you're calling your insurance company and you're not finding one, calling 988 might be able to get you to your local resource network that might be able to make recommendations about how to connect or where to connect. So I do think it's a great resource.
All right. Thank you again so much for this great presentation. Everybody, please know that this is being recorded, and a recording of this will be available to you. I don't know how shortly, but soon. And again, thank you everybody for your participation. If you have not done the poll before you check out, please complete the poll. And thank you all of you again for your participation. There's plenty more to come. And we're going to try to make sure that we continue sending resources your way, especially if you make a commitment to doing this particular bundle, which is extremely important. Thank you again, Dr. Feuer, and thank you everybody else. And Laura, any parting words before we adjourn?
Just that we will leave the poll or the session evaluation questions up until we see that the folks that are still on have completed it. And then once you've completed your poll, you may leave the session, and we hope to see you on next week's session, where Dr. Neil Uspel will talk about ED discharge and safety planning.
Thank you. And thank you all for doing the work you do.
And if the faculty